We are getting back on the horse for 2022, and no better way than with Dr. Susanna Cheng. She's an associate professor and medical oncologist here at Sunnybrook. She's been a champion and a leader for education at Sunnybrook site for the trainees, and also through the undergraduate medical oncology, the medical oncology program for the MD students downtown. And related to this presentation, she's definitely been a champion for many years, trying to devise better ways of testing for these rare mutations, and she's certainly made great strides in getting NGS testing up and running at Sunnybrook. So she's going to talk to us about the MET mutation in non-small cell lung cancer today, and some of the improvements and changes that we've seen recently. And then I guess if you have any questions, you can put them into the chat or raise your hand during the presentation.
Thank you, Ines. Okay, so let's go to my next slide. Oops, where's my next slide? Okay, these are my disclosures. Just to give a background, this is the second of a three-part series. I talked back in December about exon 20. I'm talking today about MET, and in a couple of months, I'm probably going to talk about KRAS. It may continue if I have time and topics, just to give updates every couple of months on and highlight some of the mutations that we're currently testing for, and also any of the drugs that we may have available. So these topics may continue every couple of months. I may just pick a mutation and highlight it. But today's talk is actually on MET mutations, and there's actually two MET mutations that we commonly are aware of and think of, and they're the MET exon 14 skip and MET amplification. The MET amplification is more likely in the setting of acquired resistance to TKIs, more so. The talk will also highlight the various ways to detect MET, because it isn't as intuitive or as easy as you might think. And then some of the drugs that are currently available in compassionate access or in clinical trials targeting MET and for the different indications. So what exactly is MET? So MET stands for mesenchymal epithelial transition. It's a transmembrane protein. It has an extracellular domain, a transmembrane domain, and then an intracellular domain. Just like, EGFR, it has sort of phosphorylation ATP binding sites, which upon dimerization of two receptors with the ligand, which is the HGC or hepatocyte growth factor, it causes downstream activation, and which increases survival, decrease apoptosis or decreased deaths of the cell, leading to dysregulation and cancer in general. So this is another, what we can consider a oncogene. Now, MET is not new. MET was initially discovered way back in mid-1980s, and it was discovered in a cell line for osteosarcoma. And then obviously went into sort of further testing, and it was found to be overexpressed in lung cancers by mid-1990s. And then we were looking at introduction of TKIs or EGFR TKIs like gefitinib, which came on board around early 2000. So by about 2006 and 7, they started looking at mechanisms of resistance, and they found that MET amplification was found in many of these patients. Now, mind you, the testing for MET then and now are really different. But as time progressed, they looked at the MET as an amplification in general without prior exposure to TKIs. And then they looked at MET in terms of even ALK resistance, so crizotinib in ALK patients. Probably wasn't until mid-2015, around there, that MET exon 14 became a bit of a focus. And then, kind of got my slide. Oops, sorry, too many slides. And then as we go into that exon 14, then we started doing a lot more research into targets and drugs and so forth. Now, the MET aberrations in general are not necessarily one type of mutation, so it's not so specific. It actually encompasses a various types of mutations that could be point mutations like deletions, it could be amplifications, it could be fusion. So these aren't easy to detect because you need a way of detecting them in general, or being able to cover all the different possibilities or options. But the ones that we often will be looking at and identifying, because we do have drugs that would target it, it's the MET exon 14 and the amplification in general. So we don't really do too much about point mutations or fusions at this point in the MET gene. The prevalence. So MET amplification de novo, which means no prior exposure to TKI treatments, it happens in about 2 to 5% of non-squamous patients. So it can happen. We don't see it as often. I think the prevalence is probably as high as an ALK mutation per se. I'm going to tell you a little later, but probably the reason why we're not detecting de novo MET amplification is that it isn't easily confirmed on NGS. So when we do NGS, it just tells you that it is amplified, but it doesn't tell you exactly if it's true amplification, and that requires FISH, which we don't have at Sunnybrook, which costs, I believe David told me, $500 to do if we want to request it from like PMH. So we might be missing a lot of de novo MET FISH positive amplification in patients because we're not looking for it. MET exon 14 skip, we do detect that, and we have done more of it recently with the introduction of RNA NGS, but the prevalence is in about 2 to 4% of cases. When we look at MET amplification as a mechanism of resistance to EGFR or ALK TKIs, they're about 10 to 20%. So they do form a large chunk of the reason why patients progress on the TKI. And as I said before, in the very beginning, we were doing MET as an immunohistochemistry stain, so an IHC stain. We now know that MET IHC does not actually equate into true MET amplification. And I guess everybody knows about our Susanna trial, which I'll highlight a little later, but we at first were identifying eligible patients just based on MET IHC. And then subsequently, they became much more picky, as they should be, and only allowed MET FISH positive patients to be enrolled, because MET IHC is not correlative to true MET amplification or MET mutations. This is an old slide, but it just tells you what I've just said before. If you're doing MET exon 14 skip detection, you can detect it in NGS. DNA can detect it, but MET is really more highly identified using an RNA-based NGS, which we have currently now, but we didn't have in the very beginning. So we are likely going to see a bit more MET for exon 14 skip mutations. They can do single gene acid, just like that we do for EGFR and ALK. We can do one sort of isolated detection for this gene alone, but it's too costly and inefficient for tissue-wise, so we don't do PCR for it. When we look at MET amplification, so it's down here, you can do NGS DNA. It just tells you that there is increased MET copy numbers, but it doesn't tell you if it's actually increased overexpression or just increased number of MET on the surface. So you really want to have increased amplification. I'll define that a little later, what that means. And to truly identify MET amplification, you'll need FISH to do that. Again, not at Sunnybrook, maybe as part of a clinical trial, if they have funds at PMH. So let's focus a little bit on MET exon 14 skip. So who are these people? So as I mentioned before, 2 to 4% of all comers mostly are non-squamous or adenocarcinomas. They can be actually sometimes in squamous patients as well. So 4% in adeno, 1 to 2% in squamous cell, but an extremely interesting higher proportion in pulmonary sarcomatoid. So if you have a sarcomatoid pathology patients, make sure that you do MET exon 14, meaning that check to make sure that the NGS is an RNA as well as a DNA panel, because you might actually detect this in a higher percentage of patients. Now, MET exon 14 is what we call a mutually exclusive mutation, which means that if you're MET exon 14 positive, it's very unlikely that you'll be EGFR or ALK or ROS1 positive. It can only be one or the other. Very rarely can you have two concurrent together. These patients are often older. Average age is about 72 years of age. And in general, these patients who are MET exon 14 positive have a poor prognosis. They often present with advanced disease as well. They don't respond very well to anti-cancer therapy like chemotherapy. And there's indication to show that they're not very responsive to immunotherapy as well. So response rates of only 16% and PFS of 2 to 5 months with immunotherapy. I think MET exon 14 can happen in any race, maybe a slightly higher percentage in Caucasians versus Asians. maybe a little higher in women versus men. There is, in comparison, a little bit more never smokers than smokers, but there's more in the smoking MET exon 14 positive than maybe a smoking EGFR ALK positive patient. So mostly non-smokers, but maybe some smokers that you might detect. So in general, I would suggest we do MET exon 14 or NGS testing for this in all comers, mainly non-squamous, but occasionally some squamous patients as well. As I mentioned, this is a mutually exclusive mutation, so you don't really have other driver mutations along with MET exon 14. And again, just to bring it home, it really is NGS derived, and RNA NGS is better than DNA NGS. So what exactly is MET exon 14 and how does it actually lead to increased cancer? Why is it an oncogene? So normally exon 14, it's actually on either side of it, it has introns. This one, exon introns. So introns are how we go from pre-mRNA to mRNA and then transform into a protein. So what happens is in the course of the normal splicing, the introns splice on either end, something goes wrong or wonky in any one of these mutations and so forth. And the binding site for this protein called E3 ligase, which is in the transmembrane portion of this receptor, it becomes mutated. And this location of where this ligase binds to actually is the spot where the receptor gets degraded. So if it's mutated and it cannot bind to E3 ligase, then it doesn't get destroyed, or this receptor continues to exist, it doesn't get degraded. And so you increase the copy number, which then increases survival and decreases apoptosis. So this is the MET exon 14 really is not just increasing the number of receptors, but there's actually a mutation that causes reduction in ubiquitization or destruction. So it actually lasts longer. So that's how it causes the cancer. Now, this is a case of a patient of mine, and she's interesting, and I'll tell you why. So she was diagnosed way back in October of 2020, and at that point, we did not have NGS done. So she had some unusual EGFR ALK and PD-L1, and she was PD-L1 greater than 50%. She's female, Asian, never smokers. I thought she was going to be EGFR, but she wasn't. So she went on to immunotherapy with pembrolizumab, and this is her initial tumor size in October. And then by January, it has shrunken. So there was some response to immunotherapy. Unfortunately, by September of last year, it started to grow back again with a collapse of her lung as well. And then that's when we did her NGS on her original biopsy specimen, and she is actually MET exon 14 skip positive. I was able to successfully get her compassionate access to capmatinib, and I started her on 400 milligrams BID, which I'll go a little bit more in the detail later, but that's sort of your typical recommended dose. And she derived a humongous total body rash. Her whole body was looked like scalded a bit. So I was a little worried. I took her off the medication until it settled down, as with many of these TKIs or small molecule proteins, and then started her on steroids at a higher dose of 50 milligrams a day. And then her rash got better, tapered it down, and then restarted her back on capmatinib very slowly at 200 milligrams, and then gradually to her current dose of 200 BID. But the interesting thing is that even when she was only on 200 milligrams, I would say every other day, she actually derived benefit, because this is the CT scan in February, just recently, but she hasn't really been on 200 BID for any more than maybe a week. So the dosing of these drugs, you don't necessarily need to keep them at the recommended high dose, particularly if there's toxicities. I think even a smaller dose could be sufficient. And in this case, this patient is doing very well. And clinically, just like all the other TKIs, she actually felt better after about 2 or 3 weeks of the pills. So the time to clinical improvement can be quite short and quite dramatic as well. So I mentioned capmatinib, but there's other drugs. So there's 3 types of MET TKIs. The first one, type 1, involves crizotinib, which you all know is the drug we use for ALK inhibition and also ROS1. But type 1B binds to a different location, but still at the ATP binding pocket. And we have capmatinib, tepotinib, and savolitinib. There are type 2 ATP competitors that bind to a different site, and also a type 3, which changes the shape of the binding site. Most of the drugs we currently have, oh, sorry, everyone's ringing my doorbell. Most of the drugs that we currently have available and in clinical trial involves type 1. I think they're going to be looking at type 2 in the future, because there's a possibility that type 2 drugs might be useful after resistance develops to type 1 drugs. So that's sort of the future possibility. This is an interesting slide that shows you sort of the potency of these different drugs. And the IC50 indicates how much drug is needed to inhibit the biological process by half. So the smaller amount of drug, or the smaller the number of IC50 is, the more potent it is. So you can see that capmatinib is quite potent at 0.6, and tepotinib is second at 1.723, as well as savolitinib. So these are the really good drugs. What you don't want necessarily is crizotinib, because it requires a lot of drug in order to do exactly the same thing. So fortunately, we have probably better usages of these first two drugs available in clinical trials and maybe compassionate access than crizotinib will. But crizotinib is an earlier drug, and usually we have a lot more study completion data for it. So this is the profile 1001, looking at crizotinib in MET patients. They did two cohorts. One was MET exon 14 and also MET amplification, but this is just the MET exon 14. It showed a response rate of 32%, and most of these patients are already previously treated. Median duration of response is 9.1 months, median PFS is 7.3 months. This is not bad. This is considered second-line therapy for these patients, and to have a response rate of 32% in the second-line, maybe third-line setting is actually quite good. So crizotinib is okay for this MET exon 14 if you have no other choice, but as always, we don't like crizotinib too much because of GI toxicity, but also the fact that it doesn't cross a blood-brain barrier, and so CNS disease is not managed with crizotinib. Then comes the geometry study, which is for the capmatinib. They looked at, this is single arm phase 2, capmatinib 400 milligrams BID, two different cohorts. Again, this is like a basket trial. They looked at cohort 4, which is pre-treated, and then cohort 5B, which is treatment naive. Now, it is not a very common mutation, so these numbers, sample size, N of 69 for previously treated, N of 28 for treatment naive. I mean, the numbers are small, but you'll see that the results are pretty impressive. When they looked at treatment naive, the response rates was 67%, duration of response was 12.6 months, and median OS was 20.8 months. That's quite good. Excellent, in fact. Previously treated patients, slightly lower response rates of 40.41%, duration of response 9.7 months, and median OS 13.6 months. Again, not bad for previously treated patients. This sort of made people think, now, is it true that treatment naive patients have a better response rate and longer overall survival? Should we forego even using chemotherapy in these patients as first line, because they may actually have a lower response rate if they were previously treated? So these are some of the dilemmas that we have currently. Should we get access to these targeted drugs first versus using them second line? And I think in general, if you had access to a targeted treatment first, either as a clinical trial or a compassionate program, that should probably be your first go-to. And then whatever treatments afterwards, that's in a different thought process. But targeted mutation detection, targeted drug, match the two together, patients will often do much better. The geometry study is one of the few that actually allowed patients with brain mets at baseline. Again, not a huge number of patients, only 13 patients, but response rates in the brain was about 54%. So again, better than crizotinib, which we know doesn't cross the blood-brain barrier, has some efficacy in the brain, which can show things are improving in these slides here. So it's just something to consider if you're worried that the drug doesn't cross the blood-brain barrier. Capmatinib usually will do that. Okay, I'm going to talk to you later about tepotinib. Tepotinib in the VISION study did not include brain mets patients, so we're not quite sure if it would pass into the blood-brain barrier, but chances are, because it's the newer drug, it probably does have some brain activity. Geometry study, as with all MET inhibitors, the main common side effects are peripheral edema, so about 42%, any grade. Creatinine or renal impairment in about 20%, not necessarily leading to drug discontinuation, probably some drug dose changes. But most of these patients did quite well. Only 11% of patients stopped the drug altogether because of toxicity. And I can say my patient did very well. She actually preferred the pills over the immunotherapy. Like most people think immunotherapy is easy. She liked the pills even much better when her rash actually settled down and she didn't look like a lobster as much. Vision study, tepotinib, they looked at cohort A, which is the MET exon 14 skip. They also included MET amplification cohort B, but in this cohort was 152 patients. And tepotinib, again, is a pill, 500 milligram once a day. In treatment naive patients, the overall response rate was about 45%, duration of response about 11 months, PFS about 8.5 months. In those pre-treated, similar response rates of 46%, median duration of response 11.1 months, and PFS about 11 months. So they didn't find the difference between treatment naive and pre-treated patients in terms of response rates, but the duration of response PFS is similar to the cabazitaxel study. Similarly, as all MET inhibitors, as I said, peripheral edema is sort of the main cause. These patients don't respond to diuretics or Lasix for their peripheral edema. Most likely conservative measures, compression stocking, leg elevation, maybe some dose reductions might be required if the edema is quite significant. All these other side effects, low albumin, creatinine increases, some diarrhea, nausea, they are reported, but very few of them are sort of grade 3 or higher. So again, a very well tolerated drug, tepotinib. The tepotinib study also looked at the use of liquid biopsy as a way of detecting MET exon 14 skip versus tissue, and they found a good correlation in terms of response rates. They're about the same, about 50% in both. Duration of response, a little bit different, I would say, but all in general, it's probably not statistically different. So in general, what the Vision study has added is that we can probably move forward and use liquid biopsy results to indicate tissue biopsy results. So we should be able to do plasma NGS in the future. And if they're MET exon 14 skip positive, that should be sufficient enough for the government to approve the use of, hopefully in the future, one of these drugs targeting MET exon 14. So this is just a summary slide looking at the 3 different drugs and their response rates, median duration of response, and PFS. And in general, I would say all of these drugs are good, probably not crizotinib because of the toxicity and the lack of CNS effect. Savolitinib, we are more familiar with savolitinib in the MET amplification EGFR resistant population, but there's also data that it can work in the MET exon 14 realm as well. This is sort of a publication in the Annals of Oncology in 2018 looking at immunotherapy in MET exon 14 skip. And this sort of confirms what I said in the initial slide about low response rates for immunotherapy agents and also really poor PFS. So I think, if we don't have an option of using some of these targeted drugs in the first line setting and we're just using immunotherapy and chemotherapy, then I would, have no choice, but preferably we would use one of the targeted drugs. Now, the only indication is if someone is greater than 50% PD-L1, what would you do? Would you give them single agent immunotherapy or would you give them immunotherapy with chemotherapy? And I think in that case, it might really depend on their smoking status, because if they're smokers, it probably is a higher response that they would respond to immunotherapy. But if they're a never smoker, I'd probably use a combination chemo IO for them, as long as that's something that they can tolerate. Any questions about MET exon 14? Because if not, I'm just going to continue on to MET amplification.
So Susanna, I'm just wondering if you could clarify for me,
Yeah.
in the past, for people who were EGFR positive, then they progressed, and providing they didn't have a T790 mutation, we then check for MET. So what happens to the EGFR mutation is no longer a driver if you found a MET mutation? Does the MET mutation take over and EGFR is no longer active? Or I've seen you keep people on 2 medications, and when do you do
that? That's MET amplification. I haven't gotten there yet. That's the next half.
All right.
Sorry, can I
Okay.
ask a quick,
Sure.
more of sort of a practical question about the rash? Because I have a couple patients who have also had, like one of my patients, we had to do a whole desensitization for her. And I just noticed, like, in that trial, the slide you had from the trial, it was not listed as one of the common adverse events. And I'm just
Yeah.
wondering, do we know how frequent it was in the trials? And was there a protocol for desensitization? Because I think we've been using like the prednisone as well.
Mhm.
I don't know if there's sort of an emerging, is that more of a real world data issue
Um,
that we need to wait for?
Yeah, it's going to probably come out. Barb Molosky at BC. So as much as Barb liked the whole thing about rash and EGFR, she sort of jumped on the bandwagon for rash and some of these MET inhibitors with the capmatinib. So I learned from her that rash is common. Rash that with this drug is not the same as rash with an EGFR drug. So they don't respond to antibiotics and they don't respond to topical steroids as much, but they do respond to systemic steroids. So I think there's going to be some guidelines coming out from Barb in terms of capmatinib and rash.
Right.
But
Yeah.
that's what I learned from them talking in email to Barb and to Parneet, because they have more patients than I did about what to do. And many of them also told me that the dosing of the capmatinib, like very few of them actually had patients on 400 BID. It was way too toxic. And you know, you can do either way. You can start off low at 200 milligrams BID and then move up or down. But you know, depending on their performance status, if they're not 90 years old, you might start off at 400 BID and then go down depending on toxicity. But very few of them had the ideal dosing for their patients.
Okay, that's good to know. Yeah, I think it'll be good to see just from experience some guidelines that come out.
Yeah,
Does seem to be much more common than initially.
Yeah. I think that the one thing to remember is that they don't respond to an antibiotics, because I naturally assume, oh, they're just like EGFR, maybe they should respond, but it's not the same rash. It doesn't have the same epidermal sort of irritation like EGFR drugs do. And so antibiotics does not work, topical or oral.
Yeah.
Steroids.
Yeah. Thank you.
No problem. Okay. So to answer Dr. Ng's question about MET amplification, which is the second half, where's my arrow? So MET amplification can happen as de novo or as a resistant mechanism for those who've been on EGFR first, second, or third generation. The MET amplification on itself is considered an oncogenic driver. It's just because of the increased number of copy number receptor. The extra copies just means extra growth signals are being sent, and so the cancer process sort of gets stimulated. Oops, my arrow again. So the de novo is something, as I mentioned, we don't normally test for as much because it requires FISH up front as well, but we maybe in the future will be able to do a little bit more ability to detect de novo MET amplification, but that happens in 1 to 5%. And that variation in number is because of the fact that it's so hard to truly identify these de novo MET amplification, because not everybody in the studies actually do FISH with them. And so that's why it's 1 to 5%. In general, de novo MET amplification implies a higher histological grade, more advanced disease, and poor prognosis. And they can be identified more in squamous patients. So it's very, I think in this case, what we're saying is that patients who have squamous pathology and we don't do NGS up front, and they're smokers, let's say, what we likely should do is at time point of progression, we should do their NGS at some point because they may harbor a MET amplification. These de novo patients tend to be younger, they're smokers, and they're male. And they also tend to have a concurrent other drivers like KRAS or P53 mutations as well. So again, they're not a good prognostic group of patients. Again, to highlight, NGS is okay to detect MET amplification, but NGS is not giving you the true amplification, and FISH is what is needed, and FISH we do not do. I don't know if David's here, but I don't know how we can get FISH. Maybe we can get some money from our pharma sponsors to help us pay for FISH for some of these patients who are MET NGS positive. Well, that's an idea. Whoever's doing MET inhibitor in the audience, I'd be talking to you soon. Okay, so MET amplification by definition with FISH, it's really a ratio of MET versus the centromere on chromosome 7, which is where the MET is located. So when you have a preserved copy number or increased copy number with MET and CEP7, that does not imply MET amplification. So true MET amplification is when there is an increase in the MET-CEP7 ratio. So that means there's more MET receptors per chromosome. But if it's the same, then it means it's truly not amplified. So this is where FISH can help detect true amplification, looking at the MET-CEP7 ratio. Now, there has been a lot of different studies looking at the different MET amplification. And the problem with all these studies that have been published is that there wasn't a set guideline to say what is true definition of a MET amplification. So this is one attempt to look at MET-CEP7 ratio. Anything sort of over 5 is considered high. Some studies have allowed over 2. Some studies focus mainly on over 10. Obviously, the higher the MET-CEP7 ratio, the more positive we think correlation between drug response as well. So we're looking at the MET-CEP7 ratio as looking at positivity. And again, the number to remember is probably greater than 5. To answer Dr. Ng's question, so mechanism of resistance in patients who have had prior EGFR TKIs in first, second, and third generations, the MET amplification is part of the resistance in about 5 to 50%. But you can see that there is other mechanisms of resistance, C797X, to name a few, transformation to small cell, acquisition of BRAF mutations, all of these. It can happen. It's probably one of the larger percentage, but still a small percentage. Patients who have been on first-line osimertinib, which is now the majority of our patient, the MET amplification is about 7 to 15%, and there's other mechanisms. So when we look at combination treatments, and I'll go into that in some of the studies, the idea is that we do not necessarily stop the EGFR TKI drugs. We actually continue them as well as add the MET inhibitor into it. Now, there are other drugs like monoclonal antibodies like amivantamab, which is a bispecific MET and EGFR. That on its own might be suitable, but even then, I think the study is combining that with also another EGFR targeting agent as well. Okay. So for MET amplification, it can happen anywhere from 5 to 20% of first and second line, post first and second generation EGFR TKIs. In those who've been on only the third generation as first line, it's a slightly less percentage that have MET amplification. Patients who have MET amplification following osimertinib actually have an inferior survival compared to those who do not use MET amplification as a form of resistance. And MET amplification causes resistance to EGFR TKI in an EGFR independent manner. So it's not targeting any part of the EGFR pathway. So that's why you probably should continue an EGFR drug along with a MET drug, because there may be some cells that are still EGFR TKI sensitive. Some of the studies looking at the use of MET inhibitors in MET amplification, they're not as mature as I would say in the MET exon 14 population. The TATN is a phase 1b study. It's an interesting study because they looked at different baskets of patients, those who have never had a third generation TKI, some that have had a third generation TKI, and some that were not T790M positive. So it's a busy sort of waterfall plot, but you can see that, you know, the purple represents those who have prior third generation drug. Those have had no prior third generation. Those are T790M negative versus positive. But the majority of this waterfall plot is going downwards, which indicates that there is good activity when you're targeting MET in these MET amplified patients along with their EGFR drug. So some of the smaller studies that have been available includes capmatinib, which we talked about already, with gefitinib. Response rates are 47%, and their copy number is considered greater than 6. Tepotinib with gefitinib versus chemotherapy. So a phase 3 study looked and found PFS and OS, which is significantly better than chemo. And then there's a phase 1b study that ultimately led to the Savannah trial, which is a combination of savolitinib and osimertinib in patients. So I think we'll be seeing a lot more of these combination drugs and availability coming up. As I mentioned before, the amivantamab, which is a bispecific EGFR MET antibody with lazertinib, a third generation TKI, is a study that is currently available, I believe is a first-line setting at William Hosler with Parneet right now for those patients who are EGFR positive as first line. So I'll give you an example of my other patient. She is a 86-year-old patient who is EGFR positive, seen in the community in Scarborough, presented back in October 2020 with this. One of her lesions was this, and she had mets to brain and lung and I believe other sites too. After she went on to Tagrisso, her tumor shrank as nicely as you can see by January of 2021, so after a couple of months. But then by August, it sort of grew back again here. And then that's when her oncologist sent her to see me for the Savannah clinical trial. And she was MET amplified and FISH positive. And she started on Tagrisso and savolitinib. And subsequently, this is our most recent CT scan. You can see that her big lesion has now shrunken once again, and she feels great. So at 86, she's tolerating this combination quite well. She doesn't have as much peripheral edema as I was worried about. There was some toxicity with her liver, but again, everything was, at this point, she's tolerating the drug very well. Savolitinib is normally, I believe, 600 milligrams a day. So we did have one dose reduction because of her liver issues, but she is functioning very well. So it's easy to tolerate protocol. So this may point to why some patients who are EGFR positive and may not be responding to TKIs as you expect. Maybe they already harbor a MET mutation or amplification along with their EGFR, and the EGFR drug on its own is insufficient. So, there may be an onus in the future, if we can do it, to test some of these patients that are not responding to an EGFR TKI and they're positive, to look for MET, because maybe we need to have an early introduction of a MET inhibitor in those patients. And then there is other co-mutations, and we're beginning to realize the benefit of using NGS, not just in identifying targets with drugs potential, but giving us prognostication. So we know PIK3CA is another mutation that, if detected, can actually confer resistance to MET inhibitors in those who are MET amplified. So knowing the two of them together, if they coexist, then we may be a little hesitant to say, maybe it doesn't work. This capmatinib or this savolitinib, maybe it won't work on this patient because of the co-mutation that exists. So I have adopted the next 4 slides from I believe it's a guideline published by many of our colleagues in Ontario and throughout Canada, looking at MET mutations. So they have sort of sub-summary questions and recommendations. So I thought it would be important to highlight those for us. And so one of the first questions is, how should patients most likely to benefit from MET targeted therapies be identified? So all non-squamous patients should have NGS to identify MET mutations. No brainer, should be reflex testing. All squamous never smokers, and we already know this, should have NGS tested. And it may not be reflex testing because the pathologist or the referring doctor may not realize this. So it may be up to the oncologist to make sure the never smoker squamous patients should get NGS tested. Squamous patients should at some point have NGS, because smokers and squamous patients can have MET exon 14 skip. So if you're looking for other lines of therapy after chemo IO is done, make sure you do their NGS for them at that point. There is relatively good correlation between liquid biopsy and tissue biopsy. And in the future, hopefully we'll validate plasma NGS, and in which case patients with sort of pretty high burden of disease, to which their plasma should have a lot of circulating free tumor cells and DNA and RNA, we might be able to use tissue or liquid biopsy, to actually detect for these MET exon 14 skip and other mutations. And again, the one negative liquid biopsy NGS does not mean the absence of a target. They may just not have sufficient plasma circulating tumor cells or DNA, RNA floating in their plasma to be checked. So liquid biopsies should be done in a repeated time fashion, just to make sure it truly is negative. So the second question is, what are the preferred first line and subsequent therapies for patients with MET exon 14 skip? Based on some of the small publications, immunotherapy single agent may not be the best for patients with MET exon 14 skip. even if their PD-L1 score is greater than 50%, you might have to sort of take a little breather and think, should I just give her immunotherapy or should I give her immunotherapy with chemotherapy? And those decisions would be based on patient's performance status and willingness to go on chemo as well as IO. But in general, if someone has a squamous pathology and or heavy smoker, which tends to go together, they may actually be okay with using an immunotherapy drug up front if their PD-L1 is greater than 50%. But for those who are never smokers, with an adenocarcinoma, you might want to watch them very closely if you're just using single agent immunotherapy for those patients. And then just to keep in mind the issue of immunotherapy followed by TKI, there is an increased risk of immune adverse events, including pneumonitis and so forth. Okay. What else here? Yeah, also patients who are MET exon 14 skip, if possible, preferably be if you have ability to get them onto a targeted drug, you should use the targeted drug. If not, should participate in the clinical trial. I think that's what it says. Okay. What about first line and subsequent therapies for de novo MET amplification? Unfortunately, we're not going to be able to detect de novo MET amplifications very easily. In the event that you're able to do so, the key would be putting them into a clinical trial. If there's no clinical trial that exists, then it would be standard of care chemo plus or minus immunotherapy, depending on their PD-L1 score. What is the preferred therapy for patients with MET amplification as part of a resistant mechanism of EGFR TKIs? So currently, we don't have the ability to detect the true MET amplification resistance, and that requires FISH. If we are able to do FISH, or if there's a clinical trial, the recommendation is that they should be considered for those clinical trials, because the studies are not mature enough for us to actually use MET inhibitors per se in the absence of a clinical trial, and we don't have access to drug at this point either. And the problem is, I think even if we do have free drug access to, capmatinib or tepotinib or crizotinib, the problem is that we still need to have them on an EGFR TKI at the same time as well. And often that's not covered. And so we don't have the ability to go off trial to use these combination because at least one of the drugs won't be easily accessible or paid for. So the take-home message is communicate with the pathologist, especially when they're doing DNA NGS. You might be missing some MET exon 14 skip. I think all the people in the audience today, their NGS for their patients are done at Sunnybrook. So we know that they are now including RNA NGS in it as well. So you know that we are detecting or looking for MET exon 14. Plasma NGS is coming, and I believe it'll be both DNA and RNA as well, which will be useful in detecting the exon 14 skip. There's always a revolving door of compassionate drug access. Some doors close, some doors open. We need to speak to our drug reimbursement specialists, but also to our pharma colleagues to make sure these compassionate access drug programs continue to exist. As we all know, when it comes to rare mutations, the government is slowly beginning to sort of realize that there'll never be phase 3 data, there'll never be large sample size populations in trials. They need to sort of realize that for these small percentage of patients, we need coverage for them, because targeted drugs with patients with targeted mutations, it's to their advantage. They live longer, they do better, they're better tolerated. And then we all need to learn to read NGS report. I think the idea is we need to make sure the pathologist tells us, and then they do, what's negative and what's positive as well. And yes, the pathology reports are becoming like 3-4 pages long. But you know what, it actually, when you start looking at them more often and more frequently, you get to read them and they become, less gibberish-like and more clear. So I think it's the onus of every oncologist to make sure that the NGS report is understood and realize what's missing and what we can do. And the pathologists are more than willing to help us as long as we ask them also the right questions. Okay, and that's it. It's a short presentation. Hey, got 15 minutes. Any questions? Oops, stop sharing.